Well, firstly, thank you very much for inviting me to be part of this conversation. I've really enjoyed the symposium so far, and certainly taken a lot of learning back to the UK, and was quite curious because the US is obviously much more advanced than the UK, I think, in terms of having EHR for a long time. Many of our hospitals are still very paper-based, actually. So I was wondering what I could actively contribute. And having had a chat with Kendrick, I thought what's probably useful is to share my reflections on the conversation so far from my UK perspective. So some of the things you talk about, I find quite perplexing, probably because I don't understand your healthcare system so well. I'll share some of those reflections and bounce them back as questions just in case they might be useful. I thought it might be helpful to talk about a particular case study from a UK provider organisation that I worked in before I took up my national role at NHSX. And then I will weave through this a bit of the UK story, and that NHSX and the approach we're taking now is our second attempt at a big national programme to digitally transform healthcare. So yes, reflection so far, clearly lots of learning. Dr. Chung, I've just really enjoyed your presentation, and there's some real parallels in terms of what we're saying, but I'd love to follow up with you at some point. I'm sure I took a lot from that. But what I was struck by, particularly last week, was this risk of romanticizing paper. And I had this question in my head that, is it that the further you get away from a paper record, the more you run the risk of romanticizing it, and the more entrenched you become in only being able to see the world through the EHR that you have today? Because when I think about our move, you know, our clinicians had a real problem of thinking about the world that existed without paper, and had to go on a journey into a world that was quite difficult for them to conceptualize. This notion of billing and regulation is probably quite different, because our healthcare in the UK is free at the point of delivery. That doesn't mean that there isn't a complex sort of financial flow in terms of how money gets to the front line. And we certainly aren't without regulation. But it's not a conversation that we tend to have very much. It wasn't a preoccupation with the EHR implementation I did in my last role, or a particular preoccupation with people that I speak to in my national role. We tend to think more about building from at the perspective of supporting clinical care. And I wonder what the risks are if your primary focus is billing and regulation. I'm struck by the fact that we're in a pandemic, and we've done some huge amounts of digital transformation in the UK in the space of a year that we thought would take us years and years to do, and less focused on the EHR and more around virtual consults, remote monitoring, a lot of self-care focus, and a lot of care moving out of hospital. And I think, how are we taking that learning from COVID to reimagine healthcare and the EHR? I mean, does it as a concept still stand up? Clearly, co-design has been a feature of conversations throughout, as Dr. Chung just highlighted. But what about co-design with the patient? And so far, I've seen less conversation about the patient. It's interesting, isn't it, that an EHR, like our clinical practice, should probably be sort of evolutionary and continuously changing. But when you have a sort of a monolithic system, how easy is that to do? And this divide between primary and secondary data is so interesting, because I think it comes back to this billing and regulation perspective, that sometimes we're trying to reverse engineer and build from the back end. And for the bedside nurse or clinician, it's unsurprising that they face challenges. So I'm curious about a radical rethink. And what if, instead of patient-centered, it was patient-led? I know we've talked about moving documentation from one place to the other, but would it be so bad if some of that moved towards the patient, for instance? So coming on to the case study, I think UCLH is a large academic health science centre in London. It was the second hospital in the UK to go live with Epic. So it was quite different in the way it approached digital transformation to other UK hospitals, who tend to have a multiplicity of systems and work in a sort of best of breed modality. But it's fair to say that at the time of looking to make the transformation, there was already a documentation burden. So if you look at the stats at the top from our Safer Nursing Care data set, which is how we set our nurse workforce standards each year, nurses were already almost 50% of their time away in things that were related to the documentation, whether that be retrieving data or inputting it in some way on a paper record elsewhere. There was already an existing burden. What was interesting, I think, was we had tried to rationalize a number of times, but what you end up with is bloat over a period of time, and it's hard to hardwire stuff in and make it stick. But we certainly didn't have a system where you could say, you know, we've got the best evidence-based practice hardwired in here. There was lots of narrative in the form of SOPIA notes, you know, those classic lines like slept well, lovely lady. Lovely comments, but how useful are they in terms of moving us forward in our practice? Yeah, maybe not so much. So we really thought about how could we harness this opportunity to really advance our practice and hardwire in evidence-based practice, whilst also delivering some other objectives around safety and making things more efficient. And it's fair to say, I think that there were a number of barriers to change. And the biggest one, I guess, was trust, you know, this sense that it won't work. We've tried this before on paper, it doesn't work. We work in a system where, you know, we can't rely on our Wi-Fi, the hardware's pants. This isn't going to go so well. So, you know, quite difficult to take clinicians along with you. But because we had decided this was a clinically led program and I worked as part of an MDT, I think that was key to the success of the change in the organization. We set some clear standards when we brought a group together, and it's not always our regulators that make the work that cause EHRs or paper records to bloat. When you bring a number of different clinical specialists together and they all want their own documentation that's 100 pages each into one nursing needs assessment, you find you've got a pretty vast document. So actually a lot of this is about brokering the conversations between the different specialties and encouraging people to compromise. So we gave the collective of nurses that we brought together a set of design principles to work within to both deliver this stronger nursing documentation that would support safety, but also using things like within defined limits and discrete data entry in order to try and minimize the work that they did. And I've heard a lot about clicks on this call. I was in ICU today, and so I polled a number of my nurses, and clicks wasn't something that they were particularly concerned about. In fact, they found discrete data entry quite helpful. Yeah, I guess it's about meaningful clicks, isn't it, really? But I'm curious about the notion of clicks. And I guess from that UCL perspective, you know, 3 years on, nurses actually like working with the EHR. They wouldn't want to go back. And we've certainly seen a greater robustness in the holistic nursing needs assessment of patients and patients with many more plans of care for their nursing needs. And interestingly, what we've seen is because they were so involved in the build, we had our ICNs build the workflows for infection control practice, and Epic were quite confused about this because I think it's quite different the way we do things in the UK perhaps. So we built this bespoke, and actually the organization has found that it's made the pandemic management much easier than if they had worked in the ways they were working previously. But there's still problems. UCLH is an island of 9 hospitals in a massive healthcare system. And I think there's still this challenge about what do we need to do nationally to join things up to reduce the burden, because, you know, they're still dependent on lots of information that comes in from the primary care setting through GPs. They're a tertiary referral center, so they need access to information from other hospitals. And today they don't have that. And that's where the NHSX program comes into play.
One more minute.
Okay, I will just focus on these next 2 slides, and the others are there for people to peruse later. But I guess what I wanted to tease out was I worked at a local level to make a change. I could see the limitations and where we need to do things different nationally to support in terms of infrastructure. So I take the learning from that front line into the national role, and I take it as a positive sign that NHSX want to be clinically led. We want to do something different after the previous attempt at nationalising in the UK, which wasn't clinically led. And so I take those principles, and that I was struck by the principles that you had, Dr. Chung, forward into the way we intend to work within NHSX. So one of the key objectives that I have in my role is to ensure that we have a national nursing data set, so national standards, that we will work with vendors to make sure that we can have one core nursing data set. And that's been done quite successfully with medicines management in the UK so far. I'm going to stop there. There's lots more I could say, but I think that's enough for now, and hopefully offered some things that are helpful for the conversation.